Good evening, everybody. First up, I'd like to thank Dr. Yogesh Bhatt for inviting me to this webinar, along with distinguished Dr. Mukund sir and Dr. Surajit Bhattacharya sir. My topic is on the study designs, the type of studies and their reliability. It is to declutter, especially for the beginners, to understand different types of studies and how we can uh, extend this to a publication, how it is important for us to know these differences in the when you are going to do a publication and studies. Best practices in plastic surgery, of course, is uh, because of the innovative specialty. We have a variety of procedures. The spectrum is very large, and we are going to have a lot of research questions. And the evidence-based medicine becomes much more important in this to adopt a best practice because basically evidence-based medicine is something which you have a very high quality the literature which you adopt it to your practice, to your patients, in your hands, in your setup. So that's how you can improve our patient care by using the evidence-based medicine and also the research and the publication. So it is important for us to adopt this technique of evidence-based practice. Now, how to choose a study design, because we need to see what are different type of study design, but the basic thing is it all depends on what type of study questions you are going to have and the what type of study you are going to do in your practice and where you are placed, what kind of setup and what type of patient inputs you have and what type of procedures you are going to get it. So all these will determine the study design which you are going to uh, at your whether in the beginning of your career or you have a good support system and then protocols established in your hospitals and all that. So it all depends on that. Now, if you look at the study types, there are basically two types. Basically, uh, these are analytical studies, what we call, because we are trying to analyze two different groups here. Now, if you are doing any intervention, for example, a change in the procedure or a change in the intervention by itself, or so any change in the if you're adding a procedure, if you're adding changing the intervention by changing the protocol, that becomes an experimental study. That means you are experimenting a new technique. So then you are comparing these into two groups of those who are new technique and then a new intervention to a regular one, which you have two or more groups, what you can say. The other study group is the observational studies where you don't do anything, surgical intervention or any intervention, but you allow the entire course of your regular protocol to go through and then you study the from the cause to the effect to the outcome. Okay, either it could be prospective or retrospective. So you can compare two groups also in this without doing any intervention. So you can have two groups could be different kind of age groups, or it could be a different defects or different flaps or something like that. So two different by just observation can be. In that, suppose if you don't have any group to study, it becomes a descriptive study. That means you have only, let's say, about 20 patients. You don't have anything else to compare. You are just analyzing from what are the characteristic of descriptive characteristic epidemiology to the outcome. This becomes a case series. Okay, it doesn't have any control or comparatively. The other ones which have a comparable group are the cohort studies. That means cohort means it's a two different groups or three different groups. Case control studies, that is retrospective with the control group or the comparable group, and the cross-sectional studies where you don't compare anything, you just at the one particular time or timeline or just to know the prevalence of particular issue, then you study this. The other one is experimental. We have a randomized RCTs which are non-randomized and all that. Now, in terms of evidence, highest evidence is always for the systemic review and meta-analysis, which involves the good quality research, the analysis of good quality research, like analysis of RCTs. When they're including all the randomized trial and inclusion criteria is good, and then the synthesis of the your uh, the conclusion is good when you come out with the recommendations. The next level is the randomized control trial by itself. It could be multicentric, it could be single. These are all experimental studies and they carry the highest one. And the level three are the cohort, cross-sectional, and case control studies and case series. Case series with, of course, control group or the comparable group. Then it becomes an observational group. They are the level three evidence. Level four are the case reports, where single case reports. That. And level five is the opinions, ideas, innovations, and editorials. So these are analytic studies, and this is descriptive studies where you don't have any control group, control comparison group. Okay. So these are experimental studies because it involves intervention. This is observation, doesn't involve the intervention, but both are analytic because both are comparing two groups. Descriptive, there is no comparison of two groups. Okay, this means. Now, level of evidence based, as I told you, this highest level is always the randomized control trial or the single or multicentric trials, and the with adequate power. The in between is the of course randomized control trial or the systemic review of this lesser quality randomized control trial, which and the study of these. So the systemic review can have a different kind of quality of articles. It could be a high quality RCTs or it could be just cohort articles they are doing systematic review. Then it becomes a level three evidence. Even if it is systematic review, but if it is doing a case control or cohort studies review, then it becomes a level three evidence. Level four is case series or case reports, and then level five is the expert opinion, editorials, letter to editors, and all those things. Expert opinions is basically individual opinions. Editorial and individual opinion, letter to editor is individual opinion. Survey practice could be like the survey which is knowing the what is the sort of practice of let's say anticoagulants among microsurgeons. That could be just a survey. That could be a level five evidence. Analytical studies, as I told you, is the only difference between observational and the experimental is the intervention. If there is intervention, it becomes experimental. If there is no intervention, it becomes a observation. Both are analytic studies because both you are having a comparable groups. Okay. Now, this is a clear cut. I think the analytic studies involving the experimental studies, it is always with the intervention. Observational studies, no intervention. They involve cohort studies, case control studies, and cross-sectional studies. Now, in the among these experimental studies, you can have uh, control trials. It could be non-randomized or randomized. Randomized is the highest because we are removing a lot of bias in this. There could be also an intervention without any control trials. It could be a single intervention, change of procedure, and then you can report it also. Now you know that you can do a surgery, but the fracture healing or some outcome is not exactly the same because you might do a good surgery, but the outcome may be different. So what leads to this? Then we have a unexplained or plenty of unknown confounders, which could be patient-related factors, something like patient obesity, or it could be alcoholic consumption, smoking, or his BMI may be very high, or genetically there may be issues, or it may be a social issues, or maybe surgeon-related factors, including the skill levels, his choices, and his own biases, of course, and then the intervention, the defect or the severity of the deformity itself could be the reason giving a car. So there could be a lot of confounding factors. That's the reason why this randomized control trial is designed so that we can actually reduce as much biases as possible, as much confounding factors as possible, so that we can get a highest level of evidence. So it has a very high internal validity. Advantage is it's of course it's a high level of evidence. You can establish cause and effect relationship. Good chance. Suppose if you conduct an RCT well designed, it's the chance of publication is almost 100%. The disadvantage, of course, is it's expensive, time consuming. Only narrow research question can be addressed, and of course there could be ethical issues in terms of um, in especially in surgical practice. What happens in surgical research is the because RCTs are by fundamentally it was designed during the drug trials. Okay. In surgical, there could be a lot of indications and different variables which will define the surgical procedure which you want to choose. Then you randomly allocate some things. For example, condylar fracture, if you have, they have to do a surgical reduction or just a close reduction. It cannot be just randomized. You have a lot of other variables which you decide, okay, now this is the reason I'm going to do. So there could be patient and preferences and all that. So doing a randomized control trial, choosing the surgical option, it becomes almost very difficult or not possible. But however, you can do already, which is, let's say, for example, we have a mandibular fracture bilateral, uh, which we have done rigid fixation and non-rigid fixation bilateral. So we are trying to compare complication rates. That's possible. So if you have a large number of patients with a good number of follow-up, you can do it. Randomized control trial that will give you evidence. Surgical intervention, as I said, of course, the that's the reason why the observational studies have become more important in surgical research in plastic surgery research. Observational studies are cohort studies, case control studies, and case series and cross-section studies. So these are all becoming important. They are, in fact, there are evidences to show that they are almost equal to the RCTs when you're doing a very good controlled observation studies. So that gives a enough, data or evidence to uh, prove or disprove or follow and provide a guidelines for the next level of research. And in fact, observational studies can act as a good source of hypothesis for the RCTs also. Now, these RCTs, this cohort studies can have a either a cross-sectional study, that is one time, that is only the prevalence during the present time. Okay. For example, the knowledge of plastic surgery among medical students is a one-time cross-sectional study, and the prospective cohort study could be in the prospective, or it could be retrospective, or the case control study is always a retrospective thing. In prospective studies, whenever you're doing a case series is the most common publication is because there is no control group. Most of the time, it is experience based. Uh, and of course, it's a large number of patients which can give you the publication in original articles. So you must have, if you are doing a prospective case series, then you must have at least 80% of the follow-up. That means the follow-up rate should be above 80%. Then it will have a good, it's a thumb rule in research. And you should have a good inclusion criteria. Retrospective, of course, you should have a good exclusion criteria. And there is no control group in this. So this can still become a research. Example of case series could be like, suppose if you have a new, let's say, Darwin matrix or something which you want to use it for a open wound to cover. So you can choose and do it, the research like this, treatment options in exposed tendon, and then you can come out with the safety of this product, and then you can come out with the hypothesis of this effectiveness based on the inclusion criteria and all that. It need not have a control group. So this can still be a good. And if you look at the case series, though we talk very lightly about case series in thing, but if you look at the top 50 cited plastic surgery papers in the literature, 24 are case series. One of the famous case series is Kuchen Wise, the ALT lab, which was published in 2002. He had 672 patients, labs with different applications. So he showed the flap, the feasibility of using this flap in different indications. At the same time, he didn't compare this. He didn't as a replacement to the other flaps. There was not a comparable group. So he was not showing it as a comparable group, but it was a series of these patients showing the different applications and the safety, and the complications and outcome and what you can expect out of this flap. So that's a good source of case series. So, again, preparing a case series of publication, you should have some, you know, guidelines. Like you should follow the PCOS, that is population, what kind of patients you are doing, what kind of intervention, whether it's control group is there or no outcome, and then whether it is retrospective or prospective, that is the setting, and the time period of these patients and the study period, and how long was the follow-up. So these are all very important part of the your paper, and without this information, the case series becomes very poor in terms of evidence. And data collection, of course, the descriptive data is good enough. You don't have to do a predictive value, that is p-value analysis, because you are not be able to establish a cause and effect relationship in this kind of studies. It's only the associated things which you can describe. So trying to use a p-value with this with the literature is has no meaning actually, and trying to compare. So your research complication versus the rest of the literature of this particular study, I am trying to do a p-value, predictive value. It is not going to have any meaning. So descriptive analysis of data is good enough when reporting. Cross-sectional studies is again defined population on a single occasion. Uh, there is no follow-up. There is no prospective. There is no. It's neither retrospective, but we can get. It's a basically hypothesis it generates, and we can describe one or two variables. But disadvantage is, see, there is no effect and cause relationship here. There's a lot of bias, and the confounding factors could be many. So it's not a very, but level three is okay. For example, effect of obesity and low back pain in spinal mobility, a cross-sectional study. This could be, or the knowledge of plastic surgery in medical students could be a cross-sectional study. That kind of. Case control study is always retrospective comparison of the outcome of interest, like basically cases versus the control. So the patient, you have to compare the trial with equal patient population and similar interventions, outcome parameters you have to define. And the data collection is always retrospective. Whenever you do a retrospective study, there is always going to be its own problems or limitations. So in case control studies, let's say if you have you can define outcome also. It can, whether it's a outcome is already present or outcome is not there. Okay. Now, suppose the outcome is already present, like for example, let's say group of patients, these group of patients have a thyroid CA. Okay, we are doing in that. And you want to know exposure of the radiation. So if there is exposure is present, that means the exposure is one which is going to give you the risk factor. Okay. Suppose if you don't have a outcome, now you want to study the, let's say how many will have exposure to develop cancer. Now, when you actually look at the history of exposure, there may be only one. So in the entire group which doesn't have, so you can also give the presence and absence of the exposure, basically the risk one. Okay, so you can calculate the risk factor of interest. So this is how we, in because we already have the outcome, you can compare with the outcome group with the uh, which control group which doesn't have an outcome, and then study both the risk factors, which will give you the possible risk factors, which is case control study. The advantage is it's useful, especially for rare disease and outcome, but less time consuming also, less expensive. Same time, it's a risk of bias, recall bias, difficulties in selection of control groups, and data is a problem and all that. And on the other hand, the cohort studies could be, you are studying a cohort is nothing but a group of patients which group uh, two different groups, the patient groups basically, which will have you can study one group or two groups like that. So minimum two groups, like you can add a therapy to one group and then the second therapy, which is we are not changing the intervention, but the two different therapies you can see the outcome and comparison. Okay, whether there is any complication, there is no complication. So what is the comparison between these two? For example, prospective cohort study in obesity and breast reconstruction, the complication rates in PMMC flap or the DF flaps in high BMI with obesity. So it was studied and you can make out the difference. Okay, their complications rate are much higher with the higher BMI. Two groups could be compared. It could be retrospective also. And then ability to deliver information about incidence and related risk of a disease, which we can get it. The time sequence of exposure and outcome can also be achieved. So this is the association between the exposure and outcome. You can actually the cause and effect relationship you can make out in cohort studies. The problem is it's again time consuming. If you have prospective study, then the and then we have a risk of loss of follow. Confounding variables are there. Large samples may be required in cohort studies. Retrospective cohort study could be uh, like, for example, in this, sorry, um, let's say microsurgery, the patient who underwent, mandibular resection, dental segment. How do you reconstruct? So you one group of patient, you can probably use the double, paddle fibula flap, and then the other group you used one single fibula and then the another added another flap. So it's a hybrid reconstruction of two flaps. So you compare the complication rate, you compare the lip seal and so many other issues. So you can come out with the effectiveness of the this microsurgery, this particular technique. Okay, and then it also requires a follow and the length of follow-up, and you can define the different outcomes of this patient. Then whenever you report these observation studies, initially in 20, about 20 years back, like there is a group of the editors and the researchers, statisticians, then they made the stroke guidelines. That means the strengthening the report of observational studies in the epidemiology. This is where for all the observational studies, like checklist, it could be cohort studies, case control studies, or cross-sectional studies, where you can actually have a defined reporting of these. Otherwise, there could be a lot of variables and a lot of change in the quality of the research and articles. So we need to follow because most of the journals will ask for whether you have followed the stroke guidelines. So you need to. There's a checklist. There's a 22 points checklist you can download on this. Most of the journals have this on their website. And you can when you're writing an article, you must mention that. Not only that, for the 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 observation studies, they also for RCTs we have a consult, and the systematic reviews we have to follow the Prisma guidelines. Case report there is a care guidelines, and so there is different guidelines to report. That means to prepare manuscript, you must have gone through all this. These will indicate, for example, how to write an abstract in this, how the abstract should be, what should be the methodology, what are the points that should cover, what about the population, what about the risk, what are the limitations, the what should be in the discussion, what should be the conclusion, what should be a recommendation. So many things which are comes as a part of this manuscript. Uh, I think basically this talk is on the different types of the study groups. And I would actually emphasize on the case series because which is all most of us are going to use this case series for the application, cohort studies, and case control studies and observation studies. Uh, Following the reporting guidelines is also important to get a good publication in the good journal. Thank you.